Good afternoon, everyone. My name is Dolce Sharma. I'm working as a clinical instructor in RPIT College. Today, we'll discuss about the topic seminar hepatitis B. Pathology: three antigens antibody system HBsAg and anti-HB system. HBsAg appears 1 to 2 weeks, late up to 11 to 12 weeks after exposure, persistent for 1 to 6 weeks, even 5 months in acute hepatitis B. In chronic patients or career, HBsAg persistent many years. HBsAg is the marker of infectivity. HBsAg can be found in blood and secretions, saliva, urine, semen, tears, sweat, and breast milk. Anti-HBs appears after HBsAg disappears several weeks or months, and anti-HBs is protective antibody can persist for many years. HBcAg and anti-HBc system. HBcAg can be found in the nuclei of liver cells. No free HBcAg in serum. HBcAg is the maker of replication of HBV, the stage called window phase. Anti-HBc IgM is a marker of acute infections and acute attack of chronic infections of HBV. Anti-HBc IgG is the marker of past infections. High titer means low level replication of HBV. HBcAg, anti-HBc system. HBcAg is the soluble antigen. HBeAg is a reliable indicator of active replication of HBV. Anti-HBe is a marker of reduced infectivity. If exit long may be marker of integration of HBV into liver cell. Pathogenesis. HBV invades into human body by skin and mucosa, while blood flow enters the liver and other organs such as pancreas, bile duct vessels. WBC, bone marrow, glomerular basement membrane. HBcAg, 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 HBsAg, HBeAg, and HLA1 appear on the liver cells ineffected with recognized by CTL simultaneously and lead to the cytolysis of liver cell. Helper T cells are activated by receptor of HLA on its surface, combining with HBsAg, HBcAg, and HLA antigen on B cells, promote B cell to release anti-HBs and clear HBV. The representation of HBcAg on the liver cells may cause cytopathy. Sign and symptoms: fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, clay-colored bowel movements, joint pain, jaundice, hepatomegaly. Symptoms may be an average of 3 months. Range 2 to 5 months. After exposure to HBV, symptoms typically last for several weeks but can persist up to 6 months. Clinical features: clinical illness, jaundice, more than 5 years, less than 10 years, less than 5 years, 30 to 50%. Acute case fatality rate 0.5 to 1%. Chronic infections, more than 5 years, 30 to 90, less than 5 years, 2 to 10%. Premature mortality for chronic liver disease 15 to 25%. Clinical features: acute hepatitis B, incubation period 45 to 120 days, average 60 to 90 days, phase of disease pediatric, eccentric, convulsant. Pediatric: tiredness, anorexia, vague abdominal discomfort, nausea and vomiting, sometimes atheralgesis, rash. Eccentric: within 10 days of initial symptoms, dark urine, pale stool, yellowish discoloration of mucous membranes. Total bilirubin exceeds 20 to 40. Hepatosplenomegaly after disappearance of jaundice, anti-HBs. Convulsant: anti-HBc IgM to IgG type, transient presence of HBsAg, HBeAg and viral DNA, seroconversion to anti-HBsAg and anti-HBeAg. Chronic hepatitis B after acute infection, virus remains 5 to 10% case of adult, even more higher among children up to 70 to 90%. 350 million of person worldwide are chronic carriers, among them 100 million in China. Among the persistent carriers, 70% will develop chronic persistent hepatitis and remaining 30% will develop chronic active hepatitis. Clinical outcomes of hepatitis B: acute hepatitis B resolution and fulminant hepatitis. HBsAg plus for more than 6 months. Resolution: asymptomatic carrier, chronic persistent hepatitis, chronic active hepatitis, extrahepatic disease, polyarthritis, noxidium, glomerulonephritis, cirrhosis, hepatic cell carcinoma. Hepatocellular carcinoma. Only 5% patients with cirrhosis develop HCC. HCC is responsible for 90% of primary malignant tumor of the liver. Worldwide, 7th most common cancer in male, while 9th in female. Causes more than 50,000 deaths annually, with male and female ratio 4:1. Fulminant hepatitis. Rare condition developed in about 1.1% cases. It is due to massive necrosis of liver substance. Usually fatal. Survival in adult is uncommon. Genetic heterogeneity, co-infection, host immunological factors are responsible. Thank you.